So part 2, T-cell lymphoma. I'm going to be talking about targets, new targets and new therapies in T-cell lymphoma. Hopefully they'll make a difference. Again, this is my disclosures. So if you look at pathogenesis of T-cell lymphoma, so if you try to figure out how to treat something, I think it's important to figure out where it comes from. There are three, it can be divided into three sort of categories. There are some intrinsic factors that get dysregulated. Obviously, this TCR receptor signaling pathways get dysregulated, and particularly in T-cell lymphomas, I think there is a big dysfunction in the epigenetic mechanisms. Then there is the tumor microenvironment. We know that this is very important in all malignancies, but also in T-cell malignancies, with decreased tumor immunogenicity and sort of intertumoral non-neoplastic cells that surround the tumor cells. For example, in angioimmunoblastic T-cell lymphoma, just like Hodgkin's, there's a lot of inflammation going on in the tumor microenvironment, and that's definitely contributing to your tumorigenesis and lymphogenesis. And then there are some tumors that are, some T-cell lymphomas that are virally driven or associated, particularly EBV and of course HTLV1 that is responsible for ATLL. So having understood this, I've put together sort of a list of different dysfunctional genetic pathways that are seen in the more common types of T-cell lymphomas. For example, in PTCL and OS, you have epigenetic dysregulation, you have tumor suppressor genes that are dysregulated, structural alterations in several intrinsic pathways and signaling pathways. T follicular helper lymphomas, again, I've already mentioned, heavily dysfunctional epigenetic regulators, particularly TET2, DNMT3A, and IDH2 pathways. There's also dysfunction in some of these signaling mechanisms. ALCL, you do see some epigenetic dysregulation, but more TP53 dysfunction. And then, of course, the role of ALK, which is the result of a translocation between chromosome 2 and 5 most commonly, but some other translocations as well. And then NK T-cell lymphomas, there is overexpression of PD-L1, which is why they're very sensitive to checkpoint inhibitors. And again, this is a very brief summary. On the right side, you can see the cartoon for these, trying to depict some of these dysfunctional mechanisms. They're all interrelated, obviously. So when you look at targeted therapies in T-cell lymphomas, I think one way to look at it is which dysfunctional pathways can be targeted. And on the left side of this slide, I've shown you some of the current targets that are being evaluated. We have pralatrexate that goes through the reduced folate receptor mechanism. Brentuximab, obviously targeting CD30. The TCR receptor itself is difficult to target, but the downstream signaling, PI3 kinase, a SYK inhibitor, SYK pathway. Again, this can be targeted through small molecules, the PD-1, PD-L1 pathway through checkpoint inhibitors, so on and so forth. And of course, within the nucleus, you have your epigenetic and chromatin modeling. There are some potential targets on the right side. Again, we have a paucity of CAR T-cells and T-cell lymphomas. I'll touch upon that at the end of my talk. But you have, there are some things that you could perhaps target as a result of some of these immune mechanisms. And of course, tumor microenvironment is another big area of research at the moment. So starting with epigenetic vulnerabilities in T-cell lymphomas, how do you sort of make sense of it, and how can you target that? I think the most common subtypes are that have this dysfunction. Again, the T follicular helper subtype. What I've done in this table is try to say, try to summarize some of the some of the genes that are mutated or dysfunctional and the percentages, so percent frequency in different tumor subtypes. And again, these are the most common ones in the epigenetic mechanism that are dysfunctional and can perhaps be manipulated as a result of treatments. So coming to some of the epigenetic agents, I'm not going to talk about HDAC inhibitors, but more looking at the methylation pathways. So 5-azacitidine, the hypomethylating agent. Initially, again, in the beginning of when we were looking at epigenetic agents and these agents were becoming, 5-azacitidine was being looked at in MDS and AML, I think initially the trials were negative, or initial patients who were treated with 5-azacitidine and T-cell lymphoma were negative. Perhaps at that time we didn't select the correct patients. But the French group actually looked at 5-azacitidine. And this came about, interestingly, because some of these patients have, as you know, through clonal hematopoiesis, have TET2 mutations. And for some reason, these patients with AITL were treated for this myeloid dysfunction with 5-azacitidine, and their lymphoma responded. And so they collected some data and looked at response rates were about 75%. And this was just a collection of retrospective study of certain cases. So this led to this Oracle study, which is a phase 3 study, open label, of looking at 5-azacitidine versus physician's choice. And this was presented at ASH last year. They actually looked at patients with T follicular helper subtype based on the 2016 classification. And the investigator's choice arm consisted of either gemcitabine, pralatrexate, or romidepsin. And the treatment arm obviously was 5-azacitidine. And they actually were disappointed at the results because their primary endpoint was progression-free survival, and it did not meet the primary endpoint. So the study was described as being negative, or presented as being negative. But if you look at some of the details, they felt that the study was perhaps was a little bit underpowered. But interestingly, the overall survival was improved, 10.3 months versus 18.4 months in the CC, which is the 5-azacitidine, the oral version arm. And so they've, again, useful data, perhaps not earth-shattering, and maybe this could be looked at further. There's another epigenetic target, EZH2. You've heard of tazemetostat being used in follicular lymphoma and DLBCL. EZH2 is also upregulated in certain T-cell lymphomas and is associated with actually a poor prognosis. So, and it's a histone methylation target. It's part of the PRC2 complex. So valametostat is a EZH2 inhibitor. It's a dual EZH1, EZH2 inhibitor. And the initial data in phase 1 studies of relapsed refractory PTCL was actually very impressive, leading to a response rate of about 54% in the initial study, which led to a larger phase 2 study, the Valentine study, which has not been published yet. And this is unpublished data, hopefully to be presented at ASH. And they actually, the study has now been completed. It's an oral agent, 28 days of 200 milligrams a day, given for, till progression. And the overall response rate was about 52%, which was maintained sort of across the different subtypes, I would say. About 54 to 50% in AITL and PTCL, T follicular helper. NOS, perhaps a little bit less. So this is actually better than, pralatrexate. The best response rate is about 30%. So this is starting to look very promising. If you look at the side effect profile, it's actually not bad. There were some cytopenias that could be easily managed, and it's an oral agent. So the patients have actually done very well on this. And again, we've been thinking about combination studies, but it's a Japanese company. It was kind of a little bit difficult to, they weren't interested in doing combinations till they actually had the original data. Epigenetic combinations, so learning from the myeloma colleagues, we should be looking at combinations to move that response rate from the 30% to the 60s and 70%. This work has been going on. One of the combinations is 5-azacitidine with romidepsin. Romidepsin has also been combined with pralatrexate. And again, the response rate for romidepsin, 30%, went up to 61% in the combination. This study was published in 21, and then Matko et al., they published real-world data using, subcutaneous 5-azacitidine, and the response rates were maintained. They also looked at genetic profiling in this study, and then again, they saw a lot of responses in the T follicular helper subtype, particularly with the TET2 mutation. Now, moving on to other targets. So talinapant is a apoptosis inhibitor. It's a little bit like, I'm blocking on it, right? Venetoclax, sorry. So it's one of the anti-apoptotic agents, and it's an oral agent. Phase 1 study was conducted in PTCL, as well as CTCL. So this was the combined study, and they actually had a reasonable response rate. So this was a multi-center study initially. So then this led to a combination study, which is ongoing, of talinapant with the oral decitabine. And it's kind of in early stages. They're actually having some trouble escalating the dose of decitabine. because the Tolenapant dose is fixed at 200 milligrams. So hopefully this will actually be an interesting study. We're participating in this study, but I don't have any outcome. We haven't been able to put any patients on it yet because they're still in the dose-finding study, and we can't get slots yet. But this could potentially be an interesting combination if the response is, if the data pans out, particularly combining it with a hypomethylating agent. So looking at some of the intracellular targets that are dysfunctional. So you have the PI3 kinase pathway downstream of CD3, which is dysfunctional in several tumor subtypes. And so we have several agents that are being looked at. Of course, ALK inhibitors, we already know, crizotinib, alectinib, for patients who are ALK positive and relapse, ALK positive ALCL patients who relapse, and the response rates are pretty spectacular. But looking at some of the other pathways, PI3 kinase inhibitors, there is data with almost all of them, but I think the ones that are starting to pan out are with duvelisib and limperlisib, which I'll show you in a minute. Then there's the JAK-STAT inhibitors, and then I've talked a little bit about the Tolenapant. I did a study, or tried to do a study with venetoclax. Unfortunately, we could not actually put a lot of patients on it, or the patients had to come off early because of early progression. So single-agent venetoclax was not it couldn't really be studied. So this is the PRIMO study. You probably have seen this data at ASH. This is the study of duvelisib in relapsed refractory PTCL. Initial data was with, the dosing of duvelisib was unclear. So the initial study was a dose-finding study where they actually compared 25 milligrams twice a day to 75 milligrams twice a day. In the end, based on data that emerged from that, the decision was to have like this combination dose where you start with 2 cycles of 75 milligrams twice a day. If the patients get into CR or PR or stable disease, then they go to duvelisib dosing of 25 milligrams BID to reduce the toxicity. And this is the final dosing that has been evaluated with a response rate of about 48%. Best responses are seen in AITL and PTCL. Response rates in ALCL tend to be a little bit lower. Duration of response is between 5 to 8 months. And the toxicity was reasonable. There were some liver issues seen and cases of colitis and pneumonitis that led to patient discontinuation of this study. But it's a good bridging therapy, in my mind, to patients who could then take them to an allotransplant if they respond. Limperlisib is an oral PI3 kinase, which is specific for the delta subtype. So it's a PI3 kinase delta inhibitor, and this is a study that was conducted in China. So this actually has an overall response rate of 70%, which is pretty impressive, with, again, a very similar toxicity profile. Again, a small study, 38 patients, but certainly, something that could probably be moved forward in a combination. But the response rates remain pretty impressive with a CR rate of 33%, single agent. So moving on to JAK-STAT inhibitors. So there have been work that's been done with ruxolitinib. Response rates were about less than 20%. But this is a JAKPOT-8 study with golidocitinib, which is another JAK-STAT inhibitor. Again, this study is not from the US. It's from, I believe it's China, presented at the last Lugano meetings. And here you see response rates of about 50 to 55%, which is, again, quite impressive. And the toxicities are actually better than the PI3 kinase, class of agents, mostly hematologic toxicity. So again, I think these are all interesting agents and potentially promising as well. So we are conducting a study with pasiritinib, which, as you know, is a pan-JAK-STAT inhibitor, multi-kinase inhibitor. This is, again, an early study. It's for both PTCL and CTCL. The initial dosing has been set at 200 milligrams twice a day for 4 weeks with a primary response endpoint of overall response rate. This is something that we are participating in at City of Hope, and I've put about 2 patients on it. We'll see how that goes. Now, moving on to antibodies and bispecifics in T-cell lymphoma. I mean, we have to have that talk at least in part of this meeting. So we have a couple of interesting drugs. I think this is, in my mind, this is the most exciting drug right now, CD94 monoclonal antibody. It's a study that I'm participating in. It's an interesting molecule. CD94 is overexpressed in LGL patients, and it's actually a molecule that is co-expressed with NKG2 on NKT cells, and is also expressed on CD8 positive cytotoxic T cells. So lymphomas arising from CD8 positive, the most T cell lymphomas are CD4, but there are the rare subtypes like the subcutaneous pedunculitis like T cell lymphoma. You have the gamma delta and hepatosplenic T cell lymphomas, and some intestinal T cell lymphomas are CD8 positive. And so this study is this is a study of a monoclonal antibody against CD94. So it's a naked antibody, but it engages NK cells through its interaction with this molecule, with this target. And so it's being conducted in LGL, and the second arm is cytotoxic T cell lymphomas. And this is one of my patients. So this is a patient with subcutaneous pedunculitis T cell lymphoma with, as you can see, multiple tumor nodules. This is a young patient. He was 17 when he got this disease. He's now about 22. And multiple lines of therapy, this is treated with methotrexate, cyclosporine, prednisone. And he also had HLH, so we eventually put him on this study, started this treatment in December. He's in a CR now with the CD94 antibody. And I've had 2 CRs in NK T cell lymphomas with this antibody as well. So this, I think, is very promising. We'll see how it goes. AFM13 is a CD30-directed bispecific that engages NK cells. And this was the redirect study. The study has been completed. It had an overall response rate of about 32% with a CR rate of 10%. It was conducted both in PTCL and CTCL. I'm not sure if they're actually going to go for approval or not. The company was having some trouble. But the data actually is quite solid. And the side effect profile was actually pretty impressive. And it was very well tolerated. Now, we know that the PD-1, PD-L1 drugs, the checkpoint inhibitors, are not very effective or are difficult to use in T cell lymphomas, but they are effective in NK T cell lymphomas. So we looked at the CD47 pathway in T cell lymphomas, the CD47, the do not eat me signal, which is present on macrophages. It sort of interacts with the SERP alpha, which is expressed by tumor cells, and then sort of sends this signal to macrophages to not, the do not eat me signal. So this is a tumor microenvironment modification. Blocking the SERP alpha with an antibody or blocking CD47 with antibodies is sort of something that's being explored in anti-lymphoma therapies and also in AML. This study was conducted as an intratumoral injection in cutaneous lesions. So this was not a systemic, there was a systemic application arm as well. But in this study, we actually saw responses in cutaneous T cell lymphoma with intratumoral injection, not only at the site of injection, but also in other sites of the disease. So this was sort of an interesting approach that we're trying to figure out if we can combine it with other agents. This is an ongoing list of combinations and triplets and doublets in PTCL that are being evaluated. I've already talked about the 5-azacitidine romidepsin, but there've been combinations of pralatrexate and romidepsin. There've been combinations of chitamide, which is a HDAC inhibitor, with thalidomide and cyclophosphamide, romidepsin and azacitidine, lenalidomide with romidepsin or other HDAC inhibitors. You notice that the studies are small, their numbers are small, because that's the nature of the disease. It's a rare disease. It's hard to do collaborative studies, especially when you start getting into combinations. So these are usually investigator-initiated studies with small budgets. But the response rates are starting to move up from 30, 40%, 50%, so they're starting to move the needle toward higher response rates and higher CR rates, which is what we need if we are to cure these diseases with treatments rather than transplant. So let's move on to CAR T cells briefly. So the challenges of getting a CAR T cell designed to treat T cell lymphomas has been met with some challenges. The main issue is fratricide, because you actually end up destroying the T cells instead of expanding them. There's also the concern that if you take autologous T cells from a patient, you may have some malignant T cells in there that you're going to now convert into a CAR, and it's going to really be detrimental to the patient. So the challenge has been which target to pick, because targets in T cells are not always specific to tumors, and then also how to avoid some of these combinations. So there's been some interesting approaches to do that. Then there's CD4, CD7, CD37, CD30 are some possible targets, but also modification of CARs or using NK as CAR cells to try to find the right CAR therapy. So I'm going to show you a couple of examples. One of them is this auto4 CAR. So T cell receptor, the beta component can have two isoforms, C1 and, I'm almost done, C1 and C2. So tumors will either express one or the other. So this is a CAR against TRBC1, which has been developed by a British company. And this data was presented at ASH last year of 10 patients who have been dosed with this CAR if the tumor has the TRBC1 subtype. And again, the data is early. It's mostly a dose-finding study at this point, but that's an interesting approach that I've been working on. I have a CD70 CAR, an allo CAR that's currently in clinical trials. So one of my patients who had cutaneous T-cell lymphoma, transformed disease, who was treated with this CAR. It was very well tolerated, and as you can see, his tumor on the neck responded. He actually had a good response, eventually progressed, unfortunately. And then, so this is just my last slide. Basically, conclusions are that, T cells are rare, so we need to have collaborative efforts to sort of have those larger studies to study some of these important questions. I think targeted therapies and manipulation of the tumor microenvironment and immune therapies are probably going to be the answer. I don't think chemotherapy is the way to treat. I mean, we treat it, but we treat it because we don't have better tools. But we've seen over and over again that it doesn't cure these patients. These are some of the challenges of treating T-cell lymphomas. And again, this is our City of Hope and our celebration of life, the annual BMT reunion. Thank you very much.